Hi, I'm Kaki Laraviere, and today I'm going to be talking to you about the patent cliff. Okay, so what I wanted to start out with was explaining kind of what that policy issue was. Now, the patent cliff defines the patent expiration of brand name pharmaceutical medications, and that kind of creates a mass entry of generic versions of those brands into the pharmaceutical market. And then the implications of that mass entry creates what has been called the patent cliff. And it's between the time periods of 2011 and 2016, and there are two waves in 2012 and 2015. Now, what we hear about what's been happening due to this mass entry is only in relation to big pharma, and I'll define that in the next slide. But what we only hear is there's a huge revenue loss of $60 billion due to this 5-year time period of the mass entry of generics to big pharma. And then that causes these large pharmaceutical companies to cut costs on production, which basically means they're laying off a lot of people. And so this causes the smaller manufacturers to kind of compete with larger manufacturers, so they have to merge to be competitive. And then there's also a push to do research and development in the bioinformatics side of the industry. And at the state level, I wanted to do a comparison at the Virginia level. What we've only seen repercussion-wise of the patent cliff is that there has been a stretch on the health safety net for service provision, because a lot of people who were able to get these brand name medications before they expired, those were available through prescription assistance programs of big pharma companies. So now that the patent's expired, health safety net organizations of the state have to now pay for those medications. So to kind of show you guys what big pharma looks like and what expiration looks like of blockbusters, we have the top brand names of 2011 and 2012 and their expiration dates, and then the big pharma large manufacturers beside them. So these are the companies that are considered big pharma. And just to get an idea of how much one kind of formulary of a medication costs in sales for a year, it's in the billions for each. So I thought that was just pretty interesting to organize that into a table. Okay, so also I wanted to explain what big pharma was, and the literature is really complex about this, and there's nothing really stated anywhere as to what big pharma means, but it just applies to large pharmaceutical companies that are also multinational. And there are kind of three components of the definition, and it's in regards to annual revenue, which is between 10 and 20 billion in sales, a presence in multinational markets, and then their research and development marketing efforts, and the fourth, integrated pharmaceutical operations that include research, development, manufacturing, clinical, regulatory, marketing, and sales. So what I specifically wanted to look at in this study was what's happening to the consumers, the end users of the actual medications, because that's something that's completely missed in regards to discussions about the implications of the patent cliff. And for me, I've always just been interested in looking at the social aspects of policy. So what I wanted to do was switch up the discourse and make the target low-income and uninsured consumers of these medications a viable coalition and a viable actor group that actually should be recognized. And I'll be looking at their consumption patterns, which explains their role in both the supply chain and the market, and their role that they should have in the discourse. So here we're looking at the national level agenda setting, and I just thought that graphic was interesting in that we're looking at formal policy arenas for the patent cliff. And then here it's basically talking about legislation in regards to regulation of the PAP programs and generic entry, and Virginia is not one of them. So that's also one of the reasons why we don't really hear their voice. But at the national level, we see Congress trying to facilitate generic entry in 1984 with the Hatch-Waxman Act. And then that was kind of protecting consumer rights, saying that they had a viable right to be protected by government intervention. And then next, the Federal Trade Commission kind of agreed with that and made recommendations to the Hatch-Waxman Act with the Greg Schumer amendments. But most recently, we've had the Medicaid expansion, and that also happened last week. Very exciting. But that's going to help all the state health safety nets of each state provide services and medications that were not once available with the mass generic entry. So government intervention at the national level has always been a big deal for Big Pharma, and we've heard of Big Pharma conspiracy where government and Big Pharma are hand in hand because the national economy is really supported by a lot of healthcare spending, and actually 41% of the industry itself is supported by the government, and in 2023 it's supposed to be 48. So it's interesting how we're going to see that increase over time. And at the state level, that kind of gives you a picture of what the health safety net itself looks like. So it includes free clinics, community health centers, and other health safety net organization sites. And these all experienced an influx of about 31,000 uninsured Virginians just this year. And we are actually 23rd in ranked nationally with the highest amount of uninsured residents in the state. And with our high per capita income, that's really an interesting fact because you wouldn't think that that would necessarily be the case. And that's why at the state level, it's a service provider issue, and it's coming out that the safety net is being stretched because of this increasing indicator or uninsured number, and that this extra paying out for prescription medications versus generics is causing an actual problem. So we have seen some casual lobbying efforts by providers in the state arena, but nothing really in regard to the patent cliff. It's just in regards to how Medicaid expansion will alleviate some of the implications of the patent cliff. So I did a stakeholder analysis of kind of who had power and who was at a position of influence and kind of what perspective they had in relation to the patent cliff. And due to time reasons, I'm not going to go through all of them, but I really just wanted to point out the HSNs, which is in the official section of each the national and state level, and how the providers have influence more so at the state level than they do at the national level, and then how Big Pharma always has a large presence. So that was also another visual I wanted to put up there. And if you have questions about that, I can go back later. I use the ACF framework, and I'm just going to go through and kind of outline how it applies to this. The Advocacy Coalition framework is organized through the core beliefs, and so there are two beliefs that emerge from this discourse. There's patient advocacy, and two coalitions kind of form off of that, and that's the healthcare providers, as I was discussing, and then the end user consumers, which will then focus on being the target, low income and uninsured. And then there's just profit and innovation, which is the pharmacy industry profit coalition. And then for incentives, really you see that emerge from the supply chain in branding. When you see pharmaceutical sales are really pushed and driven by wholesalers and retailers buying those drugs, really, and it's not geared towards consumers at all. So that's also how the industry itself is set up. It's set up to make sure that profits will be at the Big Pharma level. And the opportunity structures, as we have discussed, were the Obama administration and the McAuliffe administration, which is where we've heard the discourse, but it hasn't been formal in relation to the patent cliff. And then the policy change, we haven't really seen the patent cliff make it to the agenda setting phase. We've seen that it is kind of an internal policy event that is gaining traction, but there hasn't been that tipping point where this needs to be addressed as an issue. We only hear about it still at the national level only as a Big Pharma issue. And we continue to see these interactions in a closed setting because it's only discussed by providers at the state level, and then at the national level, it's only about Big Pharma. So for my research design, I used this descriptive approach, which replicated and extended Huckfelt's and Niddle's 2012 study, and they looked at models that kind of compared prices and sales data, but went beyond that and looked at utilization and pricing of patents facing expiration prior and after to generic entries. So I also did a pretest post-test design, and then the pretest was prior to the first wave of the patent cliff, so that's 2005 and 2010, and then the post-test is the next 5 years, which is actually during the patent cliff, which is 2011 and 2016, which it should be ending. And my hypothesis is it's based on that vein where we're looking at mass entry of these blockbusters or money-making brand names, and how consumers purchasing less generics and utilizing fewer drugs is an implication that should be looked at. And my dependent variable is expenses on generic drugs. So the data collection methodology here is I got my information from the Medical Expenditure Panel Survey, and I did a multiple regression analysis, and got a variety of variables to describe utilization and price for each of the top 10 brand name or generic pharmaceuticals that were purchased within those years of the pretest. There was only data that was available for 1996 to 2011, so I decided just to do the pretest at the national level. And at the state level, there was only about one variable worth of information. So I just decided to focus on really doing what I wanted to do at the national level. So results, here's the exciting part. For the generics, I found that with overall healthcare expenses, included the variables back here that was the probability of obtaining a prescription brand name, probability of obtaining a generic brand name, and the probability of obtaining a drug after generic entry, broken down by uninsured and low income in a long equation. And it turned out that the relationship itself was negative and extremely strong. I looked at the slope of the equation as well as the correlation coefficient to find the strength. And then for prescription expenses, it was positive and not as strong. But for the price of generics, healthcare expense by type, I did the expenses out of pocket, private insurance, Medicare, Medicaid, and other, and that turned out to be negative. And then the prescription, that was healthcare expense, and then prescription expense by type included the same expense type, and that was also negative. And to make sure I did this correctly, I also did generic to brand name and brand name to generic, and they were completely opposite relationships but had the same coefficients, so it went well. Okay, and just to give you guys a visual of kind of what that looked like for the top 10 drugs for each year, that was the total amount of prescription expenses in the pretest, and then the amount of individuals purchasing those drugs. So bottom right, utilization trend, top left, price. Questions?
Wow. All right, here we go.
Mom, a minute.
Anybody else want to set this up?
I can talk about limitations if you'd like.
Yeah, talk about limitations.
Okay. So this is really interesting in that I really wanted to be able to find a pattern that they had described, and the sad thing was the amount of information I was able to include didn't really allow me to do that, since it was in the pretest period. We weren't going to see generic entry actually happen. So what I was able to kind of pick out assumption-wise was when I looked at the generic versus brand name, it was really for the top 10 drugs each year. Within that 5-year time period, it was about between 1 and 3 of those top drugs each year would be brand name. No, it would be generic in regards to brand name. And also what I found was that limitations-wise, the generic version of a drug called a Simvastian, that also has 2 different prescription type drugs that also showed up in 3 of the years. So with one drug also representing 2 different drugs that showed up for the same kind of condition, I needed to control for the condition type or condition type medication, because at one point coagulation medicine was called a drug, but that was just a categorization of a drug rather than actually being a brand name of a drug or a generic version of a drug. So I had to take that out of the 2006 information, and then like the generic lisinopril showed up twice without any brand name versions at all, so it just appeared in the beginning. So I guess that had expired prior to 2010. So there were patterns that were kind of unaccounted for just in the selected data that I had.
There you go. Others? So the ACF, help me understand what the value added for using the ACF is here. What do you learn from applying the ACF as a way of thinking?
Well, for me, it kind of gave me a concrete idea behind what the core beliefs of the industry were and why the consumer wasn't involved in national level discourse, because industry marketing for pharmaceuticals only is geared towards retailers and not towards consumers, and pricing for drugs itself, again, not geared for consumers. So it's all about kind of just pricing for large sales of drugs, but the secondary buyer doesn't matter. So I
Is
thought,
that true still? I mean, isn't there increasingly marketing to consumers, direct to consumers?
that was found in this study for generic versions of the brand name drugs that had expired. But one thing that I found here was that the low income and uninsured individuals who had the option now to buy the generics, that out of pocket expense was more than they had to pay for prescription medications via the prescription assistance programs of large pharmaceuticals.
Interesting. Thank you for investing the time and effort. All right. Numero tres, that's Spanish. Number